We are talking about ischemic reperfusion injury, just a quick picture, and I want you to focus on this concept. I think that the different expression makes sense because the reperfusion injury is a temperature-dependent process. So if you use normothermic reperfusion ex vivo, we will have a full picture of reperfusion with injury to the complex 1, the subsequent ROS and FMN release, and then all the downstream inflammation and activation of the innate immune system. Using the D-HOPE, we will protect the graft, leading to a low release of ROS and FMN and an ATP recharging. In opposite of what has been said by Buffini before, in the liver, it's quite hard to understand or to predict the graft activity at the liver transplant and correlate them to the expression of cytokines during the D-HOPE. So again, the question is the same, if the cytokines are biomarkers or are the factors of something. And the other question that we have is if controlling the cytokine production could be helpful in improving the results post-liver transplant. The idea that we can manage machine perfusion in order to decrease the cytokine storm was already faced by the group in Toronto. They divided the pigs' liver grafts in 3 groups. And what they found was that during machine perfusion, the group that used all these strategies to reduce the inflammatory response showed a lower level of TNF, a lower level of interleukin-6, and especially at the beginning, a higher level of anti-inflammatory cytokines like interleukin-10. And in the following liver transplant, that was seen as a reduced level of transaminases and a lower level of bilirubin. So how can we actively work in order to reduce the cytokine storm? So we are here at Apheretica, so the first thought goes to a mechanical removal of the cytokine. So we can use cytosol, which is able to remove all the hydrophobic molecules up to 55 kilodaltons. The other thing that we found is that the use of cytosol during ex vivo perfusion was safe and feasible. So we decided to move to a very small pilot clinical trial, and we performed liver transplantation using in 6 cases in hypothermic condition, in 6 cases in normothermic condition, and half of them were associated to the use of cytosol. All the donors were very old donors, older than 80 years old. Result was definitely more interesting when we started using the cytosol in the NMP. As you can see, there is a significant reduction in interleukin-1, 10, 6, and TNF concentration. And even if the numbers are too limited to draw definitive conclusion, we saw that there was a lower median CCIH in the group using the cytosol. Just to conclude, the last things, we can actively manage the inflammatory response using machine perfusion as a platform and administration therapeutics to our graft. The temperature plays a fundamental role in modulating ischemic reperfusion injury and the inflammatory response during machine perfusion. We have no evidence that in liver transplantation, the interleukin expression during machine perfusion correlates with clinical outcomes. But for sure, it's our intention to evaluate if the perfusate purification and the removal of pro-inflammatory cytokines during excitoperfusion may have the potential to prevent the cascade of ischemic reperfusion injury and eventually improve the outcomes.